Yeah, good evening, everyone. I hereby welcome you all, and we take great pride and pleasure in bringing you the 10th series of the educational program Advanced Classes in Dentistry. This program shall be conducted with our esteemed speaker, Dr. Hussain S. Basma. This educational program is brought to you by FDC Limited, makers of the Flemiclav. Therefore, on behalf of the FDC Proxima, greetings to everyone. I now request Dr. Basma to enlighten us on the topic of are we still in the business of saving teeth?
Awesome. Thank you so much, Aman, for the kind introduction. Today the presentation is going to be a little bit different than implants, because today we are focusing more on saving. On are we still trying to save teeth? And when we talk about in the business of saving teeth, yes, it's a business. Definitely, we care about the patients more, but now the shift, I can see the shift, whether it's on social media, whether it's on live patients, whether it's on when I'm lecturing. There's always a tendency that we want to just take the tooth out and place implants, because it's more predictable. However, I believe some of the drive behind this is always business, like, oh, I don't want the headache of just doing a tooth or replacing a tooth. All what I want is just place an implant, and it's gonna definitely benefit the patient. But this should not be the drive whenever we are thinking about restoring or treating patients. The whole drive should be is this tooth can be saved? Is there still hope for this tooth? Because if there is no hope for saving teeth, then we can say, okay, you know what, we did everything that we could to save this tooth. However, now we have to move to another option, such as placing implants. But the problem here is we have to understand that there are some patients that could present to us that have severe bone resorption, that have severe caries risk or high caries risk, that those patients, they have genetic problems that led for them to be or to lose their teeth. If we look at this case, for example, this is a 21-year-old patient, 21-year-old healthy patient. He presented because he has a fistula on the upper left central incisor. And you can see that just a little bit. But if you look at this dentition right here, you can appreciate that this patient have a lot of calculus, whether it's on the lateral incisors or on the mandibular incisors. You can tell that this patient have a lot of etiological factors that could lead to bleeding on probing on some other teeth that you can see also. So we decided that we want to take a scan or take a panoramic X-ray for this patient. And that's exactly what we saw. What we're seeing here is we're seeing severe bone loss. We're seeing a periodontal disease that has a very aggressive pattern, that if this patient is still 21 and he lost almost bone to his apex, this is definitely going to create a lot of problems, leading to a lot of issues. And this would lead to more bone loss and tooth loss in the future. So the whole problem here, what we're trying to check is if this patient is 21 years old and we are trying to remove all his dentition, actually, is that possible? Should we do that when this patient is still 21 years old? Maybe he haven't finished growth yet because he's a male. Maybe he's still in the developing phase. So that there is a lot of questions that we should ask ourselves. What teeth can we save and what teeth should we remove? Because based on a certain criteria, we should always look for, especially when patients presented with such scenario and at such a young age, we have to understand that what are the factors that we look for whenever we are saving teeth. Because if we look at what can we offer this patient, we definitely can say, in any case, in any patient that can present to our practice, let's maintain the teeth, let's try to clean them, let's try to do osseous surgery, let's try to do regeneration, let's try to extract the teeth, or let's try to place implants. Or we can say, let's do a combination of everything. Let's see if we can save some teeth. Let's see if we can do some osseous surgery on the other teeth. And let's see if we can regenerate bone on certain criteria. And there are some teeth that are considered hopeless. Let's take them out and replace them with implants. So it's very important to understand what are the things that What are the things that we look for? And especially in patients who have periodontitis, there is a certain workflow that we should follow in order for us to be able to execute these cases very in a successful way. So any patient who presents with deep pockets, we have to go with phase 1 treatment. And when we talk about phase 1 treatment, we're talking about all these steps: oral hygiene instructions, medical consultation, dental consultation, nutrition guidance if the patient is obese, if the patient is underweight. We have to do scaling group planning. We have to remove all the hopeless dentition that we make sure that those are creating problems. If we keep them for the phase 1 treatment, we are controlling every single disease, whether if it's caries, whether it's plaque, making sure the patient comes with is compliant now with oral hygiene, and then we can do occlusal adjustment. If we are able to do that, then we can see the patient at 4 to 6 weeks and try to do a phase 1 evaluation where we can do what? Where we can do some physiology, where we can do some charting and check if the patient still have deep pockets. If the patient doesn't have deep pockets, we go into maintenance. However, if the patient have deep pockets, we're going to move into phase 2 therapy, where we talk about osseous resective and regeneration. And then we move into phase 2 evaluation after we do the osseous resective and regeneration. And then at the end, after we eliminate surgically those pockets, we move into the maintenance phase. So when we look at the different types of breakdown that we could have in our practice, we have 3 different types of breakdown. One is called the structural. Okay, what does structural mean? That means that this tooth might be broken due to cavities, to bruxism, to internal resorption. So this tooth actually doesn't have periodontal bone loss, but it has what? It has structural bone loss in the tooth, whether it's in the crown. And the different part, or the different option that we could also face in our practice, is the periodontal breakdown, where we have a lot of bone loss around the teeth, as we saw in the earlier picture. And this has a different treatment based on what we can offer the patient. And it could be a combination breakdown, which is both structural and periodontal breakdown, as you see in the last image. So if we have those 3 different factors, these 3 different types of breakdown, every one of these has a different treatment. Because if it's a structural breakdown, all what we have to do is either we have the option to do restore, because if it's a small fracture, or if it's a big fracture, we can do some orthodontic extrusion, we can do some crown lengthening, or we can say, you know what, let's take the tooth out and place the implants if we manage that this tooth is deemed hopeless, or if we manage that if we do crown lengthening, that's going to compromise the aesthetics. The second breakdown, we treat it differently, because we can treat it, as we mentioned earlier, we can treat it with osseous resection, we can treat it with osseous regeneration, we can treat it with scaling group planning, or we can say, you know what, this tooth is now hopeless. Why? Because there is bone loss all the way to the apex. We cannot restore, we cannot regenerate, we cannot do osseous in order to gain those teeth back. Or to make those teeth healthy. And when it's combination, we definitely do a combination of therapy. We can do periodontal and restorative regeneration, and we can say, you know what, these teeth are hopeless, let's take them out, let's place implants. So what are the things that we should know about periodontal regeneration? First of all, to define what's periodontal regeneration, it's definitely a procedure that you can attempt to regenerate the lost periodontal structures through a differential tissue response. And when we talk about the periodontal structures, we're talking about bone, we're talking about cementum, we're talking about PDL, because the whole purpose of this is to definitely reform the epithelial seal that we created. We definitely want to have a deposition of the cementum, as we mentioned in the periodontal structures. We are going to talk about restoring some of the alveolar bone that we lost before. And the most important thing is the insertion of functionally oriented connective tissue fibers, which is basically the PDL. So what we're trying to do here is very unique. We're trying to attempt periodontal regeneration that we can only check by histology, and the whole thing is to recreate what we've lost by creating a whole new attachment apparatus. Again, as I mentioned, it's all about the cementum, the bone, and the PDL. But the most important thing that we should know is that we have to have something that prevents the apical migration of the gingival epithelial cells and the connective tissue during the healing time. And that's why we should always place a membrane in order to prevent this invasion by the soft tissue during the healing time of the bone. Why? Because all the growth factors, all the regenerative potential comes from the PDL. And because the soft tissue heals faster than bone, we have to keep or give time for the bone to heal. Maintenance of wound space into which selective populations of cells can occur. This is also to do what? Is to prevent the ingrowth of the soft tissue in order to allow bone to grow there. And this can only happen by the use of a barrier membrane. So what's a barrier membrane? A barrier membrane actually is a membrane that you should use in order to prevent the epithelial invasion, as I mentioned, in order to allow bone that's a slow healer during the healing time and come during the healing process and prevent the invasion, as I mentioned, for the soft tissue, so it doesn't impact the healing of bone at that time. So we have different types of membranes, and the whole purpose is to recreate the intrabony defect. But when should I consider regeneration in these cases? Because there's a lot of factors that we should look for. We should look for clinical factors such as site-related factors, such as etiological-related factors, and such as variables-related factors. When we look at site-related factors, we're looking at the cervical. If there is any cervical enamel projections, we have to adjust that. Are there any enamel pearls that led to the bone loss? And these are all definitely some enamel functions, that enamel deposition that could lead to bone loss because soft tissue does not attach well to enamel. So we have this will create sometimes some areas that will deposit bacteria and lead to attachment loss. So in order for us to gain the attachment, or at least to prevent further attachment loss, we have to correct those enamel problems by removing them by surgical burr, by removing them by chisel, and also we have to check if there is tooth mobility. The tooth mobility is a big thing. If we were trying to attempt regeneration and there is tooth mobility, that's not going to work, because the most important thing in regeneration, whether it's in the hand, what's in the leg, whether it's in the teeth, whether it's in the oral cavity, it's all depending on stability of the clot. And that's very important, because if I broke my hand today and I don't put the cast, my hand is never going to heal well. Why? Because every time it moves, those anastomosing new blood vessels are going to be broken down, and this will lead to what? This will lead to impaired wound healing or impaired healing of the soft tissue. Another thing we also should consider is the gingival thickness, because if the soft tissues sometimes it could impair the wound healing. So in order for us to do that, we might consider some grafting before. What is the etiology? Why are we losing this tooth? Did the patient have a trauma? Did the patient have really a severe periodontal problem, as we saw earlier in that case? Do we have a lot of plaque? Does the patient compliant with oral hygiene instruction? And also we look at, is the patient healthy? Is the patient a smoker? Because maybe that will impact our treatment modalities. And then if the patient is smoker, should we consider regeneration? If the patient have uncontrolled diabetes, what should we do next in order for us to attempt surgery? So it's all related to those clinical factors. And we should never forget that this is a costly treatment. We are going to do scaling group planning. We're going to do extraction. Sometimes we're going to do a bone graft. We're going to do an implant placement. We're going to do a crown. Sometimes we might do additional grafting for sinus. So it's all very costly treatment, and we have to understand that patient's ability to further pursue in this treatment. And also compliance. And I always say this, especially if we want to consider implants. If a patient lost teeth due to poor oral hygiene, that doesn't mean he's not going to lose his implants due to poor oral hygiene. So we have, and teeth are different than implants. Teeth are way stronger than implants, because teeth have the privilege of the PDL, which is the periodontal ligament. This is the best nutritive sites and the best nourishing site, and have the best regenerative potential. However, implants doesn't have that privilege, and any problem that can occur around an implant, this could be more devastating. That's why patients who are having or going to or plan plan to having more implants or implants, they have to be very compliant with oral hygiene. They have to be healthy so that we don't create more problems. So when should we consider regeneration? We should consider regeneration in 3 different modalities. One, if we have a class 2 forcation. Number 2 is if we have an intrabony defect that is well contained, that has a good blood supply, and we'll talk about that in just a little bit. And class 3, we consider regeneration whenever we're considering soft tissue regeneration, but this is not going to be our topic today. And when we're talking about forcation, we have to understand the different classes that we could have during forcation involvement. Class 1 forcation is actually non-treatable because it's just starting, okay? It doesn't have like a good contained defect. So all what we can do in some cases is basically we do not recommend regeneration in class 1 defect. And we can measure that by the neighbor's probe. And that means that we should understand those 3 different classes. Class 1, the probe doesn't goes less than 3 millimeter into the forcation. Class 2 goes more than 3 millimeter but doesn't go through, and this one has the best potential for regeneration, especially when the interproximal bone between on the adjacent teeth between that. Let's take that forcation on tooth number on the first molar. The interproximal bone between that tooth and the adjacent teeth, if it's high, that means that this is a good potential. This defect has a good potential for regeneration. And class 3 forcation is basically if you have a through and through defect where the forcation can go all the way from the buccal to the lingual in the mandibular forcation, and this is very rare that you can offer the patient some regeneration. And here we can consider alternative of treatments such as tunneling, as you see in this picture, such as maybe in some cases, because we might consider implants nowadays, we can say, you know what, this is hopeless, we can take it out, or we can just maintain it until the patient lose more, until this tooth is deemed hopeless. So class 1, we look at osseous resection. Class 2, we look at possible regeneration depending on where the position of interproximal bone is. And class 3 is very rare that you can be able to do regeneration, probably maintenance, and give the patient a better access to clean those forcations. So what are the things that we look for in the defect in order to say, well, is this defect regeneratable or not? Because we have, as if we look at this picture right here, we have different kind of defects. We have this small defect, this shallow defect, this deep defect, this V-shaped defect, this crater-shaped defect. So all these should be taken into consideration. And the most important things are 2 things that allows you to decide if you can do regeneration versus resection. And if you want to take one thing from this presentation, just stay with me on this slide because it's very important, okay? So 2 things that we look for whenever we want to see if this intrabony defect should be regenerated versus not, is 1 is the defect angle, and 2 is the defect depth. Definitely, and another important thing is how many bony walls do we have. The more bony walls, the better, or the more osteogenic potential is for that defect. So the defect angle, if it's greater than 37 degrees, meaning it's a wide defect, and if the depth is less than 4 millimeter, meaning it's a shallow, very shallow defect, we cannot do regeneration in these cases. Let me repeat that. If you have a wide defect, very wide defect, and it's very shallow, this is a not good defect for regeneration. We should do osseous resection surgery. However, if the angle is narrow and it's a deep defect, then we also are going to look at the number of walls, 1, 2, and 3 defects, and 3 walls. And you will see that the more walls, the better regenerative potential. So what does that tell us? Tells us that we have to look at the depth of the defect. If it's shallow, that means we're not going to regenerate. If it's very wide and shallow, also it's not going to regenerate. And also the number of walls, it's important so that you know how much osteogenic potential your defect is able to. So if you have 1 wall defect, or before I move into this, I want to say the more walls, the more osteogenic potential. Why? Because if I have more walls, the defect is well contained. However, if I have less walls, now I'm asking for a more regenerative potential. And the other thing that could hurt us is that this defect is not going to be well contained. So I have to make sure I'm using something that will at least help in restoring those bony walls at the time of the healing. So in those cases where we have less bony walls, we should consider using a membrane. And this is called guided tissue regeneration, as I mentioned earlier. So we do osseous surgery to remove the unsupported one wall defects, or we use a resorbable versus unresorbable defect with bone graft, and then we close it up, we let it heal, and then come back. Whenever we talk about two wall defects, we're talking about either GTR only, which is a membrane, or we can talk a mixture between GTR, membrane and bone graft. With class 3 defects, or I'm sorry, not class 3 defects, with defects that have more bony walls, okay, now we can use some biomaterials only, like bone graft only, or a membrane only, or some other factors. So we have to understand that the three things that we have to always look at is the defect depth, how deep is the defect, what's the angle of the defect. If it's very wide or if it's narrow, the narrower the better, but the narrower to a level where you're still able to clean that defect. If it's very, very narrow that you cannot access to clean the defect, this is a defect that you cannot regenerate. Okay, and also the number of walls. The more number of walls, the better for us. If we have less number of walls, now we should start considering supporting that regeneration by using a GTR or a membrane. Okay, and when we're looking at all the different options that we could have in our material, we have a different type of bone graft, we have different types of membranes, we have different biologics, we can also use a combination of all this. But in most of the time, we have different types of membranes, right? We have resorbable versus non-resorbable. We have tie mesh. We have in resorbable, we can have a cross-linked versus non-cross-linked, which is basically, and we're going to talk about that in different lectures. Cross-linked and non-cross-linked, basically one of them is being treated to last longer, which is the cross-linked. So in those defects, this is what my go-to membrane is, the cross-linked resorbable barrier. I don't use non-resorbable anymore, just because I don't want to go in and then remove this membrane. And also, if this membrane gets exposed, then it's going to create some problems. And tenting devices, this is mainly for, as a tie mesh, this is for vertical rejuvenation. This is not used in intra-bony defects. So the go-to here is always the cross-linked membrane. Bony substitutes, we can use autogenous, which is number one, our golden standard. We can use allograft, we can use xenograft, we can use alloplast. However, with allograft, we have different options to be used, which is the fresh and the frozen. Now it's not used anymore because of the high immunity reactions to this type of bone. And also we have the mineralized and the demineralized. The difference between the mineralized and the demineralized is one of them has been, we remove the mineral in order to expose more BMPs. And this is actually the most important bone that we can use in such defects. We want defect that could have a good osteogenic potential, that could have exposed the BMPs and lead to a good regenerative potential in that defect. Also, we can consider Emdogain, which comes from the amidogenine. We consider GEM21, which is the PDGF or PRF mixture that helps also with the healing. But keep in mind that PRF is only for soft tissue. PRF does not help with the bone healing, it helps with the soft tissue grafting. PDGF and Emdogain both have a proof of principle that they cause regeneration in intraosseous defects. So let's take an example. Let's take this case, okay? And we're going to take only two cases, and then we call it a day. And this is a patient that presented with a big diastema between tooth number 8 and 9, which is the upper central incisor. So we had a deep pocket. Also, you can see on the bottom left image, on that lingual surface of that central incisor, we have a lot of pus coming out from the defect, right? And we took a 3D X-ray and we realized that this tooth have what? This tooth have a very good, well circumferential defect. And what is that telling me? That tells me that this is a well-contained defect, and we're going to see that in just a little bit. So we said, okay, you know what we're going to do? We're going to do regeneration. We're going to do deep cleaning, and then we are going to move the patient into the treatment. So we follow the same sequence as I mentioned earlier. Phase 1 treatment, which is basically scaling group planning. we do fix the occlusion. If this tooth is moving, probably we should consider splinting the tooth. And also we should also consider the oral hygiene instructions from the beginning. And then the patient came back after 4 to 6 weeks, and we decided that this is a case for regeneration. And even though we did scaling root planning, you can appreciate in the first image on the mesial aspect of that central incisor that we still have calculus present, and that's the importance of doing a surgery. So we cleaned this area really well, and then we did a very good scale root planning, and then we decided that we wanted to evaluate this defect. So let's evaluate this defect together. Okay, so what is this defect? First of all, we look at 3 things. Okay, number of walls. Here, this is a defect that have at least two walls, which is well contained, so it's have a good regenerative potential. It's a deep defect. It's definitely deeper than 3 millimeter. However, it's wide, but still, because I still have two well circumscribed defect, the tooth is not moving much, and also I'm still able to clean the whole defect. Now I decided I'm going to do some regeneration. So in this case, what did I use? After I did my root planning, I used EDTA, and this is just to remove the smear layer and also create a better regeneration. I used an allograft material with GEM21, which is the PDGF. Also, I used the membrane. And in this case, what did we use? We did bone graft, we used the membrane, and then we close it up and we let it heal. Patient came back, and that's how he looks at the healing. What are we looking for here? This is initial. At 1 month, you can see how the bone is still healing. And at 1 year, you can appreciate how much bone we have created again back. Okay, so yes, we could have considered implant. We could consider taking the tooth out, but now we are still able to do what? We're still able to regenerate this defect. So could we have done this differently? Maybe. Could you consider implants? Maybe. But this is a not high aesthetic case. The patient probably didn't want implants at the beginning. The tooth is not moving. Now this tooth at least is going to survive for the next 5-10 years if the patient have a good oral hygiene. So why should I consider implants from the beginning? However, there are some other cases where I say, you know what, I cannot consider regeneration here. I will definitely go with the option of extracting teeth. I will definitely go with the options of missing, placing implants. So it's all different. So let's go back to this young guy that I told you about. So this is what we did in this case here. If we look at this X-ray here, we can definitely tell that there are teeth that are hopeless. You can definitely tell that those mandibular incisors are hopeless. You can tell that the maxillary premolars are hopeless because they are class 3 mobility. First molars maybe are not in the best condition. So what did we do in this case? Just look at this. Calculus all the way to the apex. Calculus all the way to the apex. Can we regenerate in these cases? No, we don't have bone. The teeth are moving. They are literally, I can literally remove the teeth without using a forceps, just by my hand. They are class 3. If there is a class 4, I would say class 4 mobility. So we take most of the teeth out. However, we try to save the rest. Why? Because I want those remaining teeth during this time to be supporting the teeth, supporting the bone. But however, we gave the patient a good oral hygiene instructions. As you can see, the quality of the tissue now that we have, that fistula is completely gone. We don't have much bleeding on probing now. We did a good phase 1 treatment. We did a good phase 1 therapy. We removed we removed the hopeless dentition. Even though we still think that we are going to lose some teeth in the mandible, we decided, okay, you know what? Let's try and see what we can use in this case. Can we do regeneration, or should we just take the teeth out? And here we were able, just by opening the flap, we were able to manage those defects that we should use what we should use. We should do regeneration. So we used allograft with a mixture of allograft and Emdogain in this case, and also use a non-resorbable barrier in between those teeth just to support the tissue well. And the patient came back after this, and we were still able to maintain all his mandibular teeth, even the first molar that looked very hopeless. And this is how the case looked before, and this is how the case looked after. Well, we were able to save the bone. Yes, we didn't have regeneration all the way to the top of the defect, but definitely we gain some regeneration. How do I would say bone fill, because I cannot tell this is a regeneration or not until I do my histology. But this tells you what? This tells you that I'm able to still save teeth in this business, in this area. We are still in the business of the saving teeth before we should consider implants, and always weigh the benefits. Always weigh the benefits. Okay, how many of us have peri-implantitis? How many of us will have these problems? We definitely should always think about saving teeth first. Why is that? Because two different schools. One of them is that if you take those teeth out, place implants now, if the patient has this bad oral hygiene, calculus all the way to the apex, do you think that if this patient was not very serious about his treatment, do you think he's going to remove those? He's going to take care of his implants? We're going to end up with very complicated scenario. Okay, so we have to understand from the beginning the different factors that we should look for whenever we consider regenerating implants and regenerating around teeth or saving teeth. What are the factors that we look for in the defect? What are the things that we should do before regenerating the defect? What is the different material that we should use whenever we're regenerating the defect? If we can do this, then we are sure going to be able to save teeth, and we're still in the business of saving teeth. And let me tell you one thing. If you are thinking about teeth as a business, it's a problem. And I want to correct you that we are not treating patients only because we want to make more money. We are trying to save them. We're trying to help them to save their teeth, to help them to a better quality of life. And all what we do is patient oriented. Okay. But however, if you still want to think about saving teeth because of business, or extracting teeth or treating teeth because of business, think about it this way. Okay. The second you take this tooth out and you place your implant, that's the second you start losing money, because anything that happens for that implant, now it's your responsibility. And that's why you should always think about restoring or regenerating teeth, regenerating defects. You should think about the last option should always be to count till 10 before you take the tooth out, and weigh the benefits. Again, weigh the benefits. Look at the defect. Can I still save bone? Can I still save those teeth? Can I still do anything to help those teeth to survive for at least for the next 5-10 years? If so, definitely go to saving the teeth. If not, then do not take the risk. Just take the teeth, because now we don't want to lose more bone. That's going to compromise your implant placement. And then you can go with what? With extraction, bone graft. Let it heal for 3-4 months, come back, place implants, and then call it a day. But before you place implants, make sure that your patient is compliant, make sure your patient is healthy, and the patient is aware how serious is if he doesn't take care about the implant, that this is going to be more problematic. I think from this presentation today, I'm going to wrap up in the next 2 minutes. What we can tell from today is that before you look at any patient, look at 3 things. Okay, intraoral exam, X-rays, and if you want to have more information, take a 3D X-ray to see what type of defect you want. Or you can do that intraoral exam by probing multiple teeth sites. You can tell approximately how many walls you have. When you open the site, always manage. Then before you open the site, always check the mobility. If the tooth is mobile, you should splint the tooth if you consider regeneration. This tooth should never be moving. Okay. Don't probe these patients if you attempt regeneration until 6 months from healing. Don't probe. But make sure during this time you're seeing the patient for maintenance, for cleaning, and also trying to keep up with those regenerative defects. Most of the time, you're not going to, as you see in this case, you're not going to be ending up with restoring bone or regenerating bone all the way to the top of the defect. At 6 months, when you come back, probe the patient again. Sometimes you have, and literature shows that, sometimes you have to go with an osseous resective defect just to shape the bone to create a flat or a positive architecture. You should always consider that. And with that, you should always put a patient on a closed maintenance interval. You don't want to place your implants, or you don't want to do regeneration, and then the patient disappears, comes back with poor oral hygiene, lost the bone that you already regenerated. You should not do that. Very close maintenance interval every 3 months, maybe less than that if the patient is not very healthy. And I think With that, we should definitely always think about regenerative bone. We should definitely don't go crazy with the options that we have, as you see in this denture. There's a patient that has 2 rows of denture. I saw this patient literally in the clinic. I was surprised. And it's not about creating alternatives for teeth. It's basically trying to save those teeth first and then try to find out alternative for this dentition. And again, with that, I want to thank you guys for your for your attention. And if you have any questions, feel free to ask them now. Thank you so much.
So, well, with this, we have come to the end of this very educative and interactive session. I'm sure the audience would have gained a lot from the today's discussion. A big vote of thanks to Dr. Basma for sparing his valuable time and being with us. I would like to thank our educational partners, FDC Limited, and CME partner, Spiren Communication, for conducting of the program. So happy weekend to all until we meet.